No worries. Okay, I'm going to be admitting the students now, and then Amna will be going live, and she'll start with the session.
Perfect. I'm just loading my computer. I don't want it to die.
Good morning, everyone. Welcome to TeleShadowing. We are recording the session and live streaming it to YouTube. TeleShadowing is a shadowing program open to all pre-health students from the undergraduate, post-baccalaureate, and high school levels. We are firm in our mission to extend shadowing opportunities to students across the globe. You will receive certification after this session via a quiz and a brief written reflection. We recommend you to complete these quizzes as soon as possible, as there's no extensions after the deadline has passed. More information can be found on our website at TeleShadowing.com. We will be having a Q&A session at the end, and you can ask questions in the YouTube Live and Zoom chat box, and they will be addressed.
I'm honored to introduce Dr. Safdar. Dr. Safdar is an adjunct professor at the Baylor College of Medicine. She is the Director of Clinical Research at the Lung Center, Director of the Pulmonary Fibrosis Center, and the Director of the Pulmonary Hypertension Program, all at the Houston Methodist Hospital. I would now like to request Dr. Safdar to start today's session. Thank you.
Good morning, everybody. It's an honor to do a teleshadowing session. This is the first time that I'm doing a teleshadowing session. I've done many Zoom meetings that all of you have, and I have done a lot of mentoring. And let me see if I can share my screen so you all can see. Everybody can see this?
Yes.
Perfect. So I'm just going to go right ahead. I'm an adult pulmonologist, and I started my career long time ago with the med school. So I did my undergrad, then went to med school, then gave my exam, did my residency. I think one other speaker, a couple of other speakers have already gone through this timeline. So I'm not going to bore you this, but as you can see, it's a timeline that seems very long. Suffice to say, anything in life that you put in more effort, you get more rewards. So the more effort you put in as a young person, the more rewards you're going to get towards the very end. And some people say that we don't want to work very hard or very long. The problem in life is this, that we all have to work hard no matter what you do. So the harder you work, the better rewards you're going to get. That is my assessment in a nutshell of a life. So anyway, so I started my med school in Karachi. I was born and raised there. And then during my med school years, I started thinking about what should I do as a postgrad. And I really loved ICU. And in the ICU, when I was doing my rotation as a student, med student, I really wanted to do that. As an undergrad, when I was growing up, my aunt was a doctor, so I spent a lot of time, my summer vacation time, and when I was visiting her, a lot of time in her clinic, and I really loved it. So I wanted to be a physician from that point onwards, and I think that never changed. And then to plan ahead, and during med school I started giving my exams, and then one thing led to another, and I came to downstate in Brooklyn, and I did my training there. I worked on the research project during that time also. So it's just how dedicated you are in terms of yeah, in terms of your research, in terms of doing extra projects, just doing some extra works. People, generally speaking, I think in anything in life, if you get along with people, and if you are nice to them, they will give you different projects, and that will help you in your career. That is Dr. Cam Holz. He is the program. He's retired now, but he used to be a program director with a photogenic memory. So any of the med schools students here, Harrison is a Bible of medicine, internal medicine, and you could tell him something, and he would say, "Oh, it's on page number this, on volume number this." So he had a photographic memory. Very nice guy. So then I went, did my residency over there, and then fellowship, followed by pulmonary critical care fellowship at St. Luke's Roosevelt Mount Sinai in New York City. And during that time, I also finished my clinical fellowship, and then I did my research fellowship and stayed an extra few years there, and as also as faculty before I became a faculty at Baylor College of Medicine. I don't know where. Oh, here it is. And I came over here at Baylor College of Medicine, and I joined as an assistant professor many years ago. And during this time, when during this time when I was at my postdoc training, I worked in a lab, and we published some interesting papers with basic science research. So that was just, if I would have taken another route, you could have said, why did you do this? I could have just gone into and become an attending, do a private practice. But because I wanted to stay in academia and do teaching, I had to take this route where I would have to go and work in a lab for a few years to see what the research is all about, to see if I like it, and then go ahead and then transition whether I want to do primary, just basic research, or translational research, or basically a private attending in a private practice. I tried working as a general pulmonologist. I really didn't like it. So I came over here at Baylor as an assistant professor in academia. I started working on different research projects. My interest, the person that I joined, and the interest was pulmonary hypertension and ILD, and that continues to be my interest, which is a good thing, because I have no training in my clinical translational research. I joined a program, and it was sponsored by NIH, and that led to an NIH grant actually. And I stayed there, became an associate professor and the director of the pulmonary hypertension program that I worked in. And then I moved over to Methodist about 5 years ago, and now I help run the Houston Methodist. We set up a lung center there, and now we help and run the Houston Methodist Lung Center, and we take care of all these different diseases that are outlined over here. All are pulmonary, of course, lung related. So I thought maybe I would go over what is pulmonary hypertension. I thought that maybe something, just my life may be too boring. So I thought I'll talk about what is pulmonary hypertension. And in basically, it's a very rare disease, predominantly happens in female. Like you put a cuff in and you say, okay, this is my blood pressure. The same way, there's no cuff that you can put around your lungs to say this is the high pressure in the lungs. So the most common way of checking it is doing an echocardiogram, the ultrasound of the heart. And it can be rapidly progressive disease. It has a poor outcome. There have been multiple clinical trials, as you can see over here. These are the names of the trial. They really put nice name. If you can see over here, Alphabet, Stride, Step, Combi, Triumph, Paces, First. So all these studies our center was part of it, and we have been participating in clinical trials for a long time. This, I explain it to everybody. This is like if you have a tube, and this is a lung, and this is the right side of the heart, and this is the left side of the heart. So the blood flow into the right side and drains into the right side of the heart. It goes into the pulmonary circulation, the lungs, and then it oxygenates it, and then the oxygenated blood then goes to the left side, left atrium, left ventricle, and then it's pumped, and that creates the blood pressure. So it's like almost like a tube. And the reason why it's a tube is because we don't ooze blood on the outside, right? It's a closed circuit. It's a pump in the middle, the deoxygenated blood coming from the right side, from the brain, from the arm, from the legs, from the belly, goes into the heart, goes into the pulmonary circulation, and then into the left side of the heart where it pumps it. So any problem anywhere along this line, along this pump, will create problems. It can be lung problem, can be heart problem, can be a lot of problems. So what we are concerned about is there's a problem with pulmonary circulation over here. So that's the main problem. So what can it be? It can be a clot that can come in to the legs or to the belly and cause problem. That's thromboembolic pulmonary hypertension, which is high pressure in the lung leading to high pressure. It can be the alveolus or the lungs that's getting destroyed because people smoke a lot, or they get bad pneumonia, or they now COVID pneumonia, post-COVID patients are getting a lot of lung fibrosis or scarring of the lung, and that leads to destruction of the lung parenchyma, and that can lead to high pressure in the lungs, any cause sarcoidosis, COPD, anything. Post is would means that the post capillary would mean that that they have a problem going from the left side of the heart. The LV or left ventricle is not working properly, or the valves are not working properly. So it's just like a pump, right? So it backs up into the lungs, creating pressure, high pressure in the lungs. But the problem is not the lungs. Problem is the left side. So that has to be fixed. Or the one that we talk about is the idiopathic pulmonary hypertension, which is it is the problem with the precapillary arterioles, and we don't know why the problem arises. It's idiopathic or associated with lupus, scleroderma, or connective tissue disease. Sorry, I'm just trying to move. So these are the different five types. I talked about the pulmonary arterial hypertension, where the intrinsic problem is in the pulmonary vasculature. On the other side, the left side is the left heart, lung disease or hypoxemia, or it could be blood clots, which is the chronic thromboembolic, and the miscellaneous causes. A lot of medication that we have available is for group 1. We have medication for group 4, and now recently we just got FDA approved for medication for lung disease associated pulmonary hypertension. And in the lungs, if you look at the capillaries in a biopsy specimen, you will see that the vessels are not open. They are just pretty much closed up by overgrowth of vessel. And another way of looking at it, this is where the vessels are, the vessel wall is thickened. There's a little thrombus there to the point where it completely gets sclerosed and thrombosed. And another way of looking at it is this is the vessel wall, which is thin walled and flow is no problem. And the vessel wall becomes thickened to the point where it's narrowing significantly, creating a back pressure and leading to pulmonary hypertension. As long as the cardiac output is maintained, there's no patients don't feel any problem in the presence of increasing pulmonary artery pressure, which is PAP. But as the pressure keeps increasing, a point comes when the heart says, okay, I had it, I cannot do this, this is too much work for me, I cannot manage it. So then the cardiac output starts to go down, and that's when the patient starts to feel more short of breath. There's another, I don't know if there's any physiology buff in your crowd, but one is the cardiac output on the X and the mean pulmonary artery pressure on the Y axis, showing that in majority of us, if we happen to go to the gym once a year, twice a year, we can increase our cardiac output to 15 liters, 20 liters on a treadmill, jogging, or whatever you want to do, or go for a walk outside fast paced. You can increase your cardiac output, and your pulmonary artery pressure, mean pressure, do not increase. Normal people, me and you, hopefully, are here. But patients with pulmonary hypertension, as they start to increase their normal cardiac output around 5, they double their cardiac output or triple their cardiac output, their pulmonary artery pressure now starts to rise because their lungs are not able to hold that increased amount of blood flow through their lungs, because the vessels are not they cannot dilate as they normally do in our lungs. Our lungs are very able to accommodate this high flow without any problem, and it's called recruiting the lung vessels, because they're staying there dormant, not being used. God has given enough reserve. I thought, because I usually tell my patients that we have enough reserve because God knew we are going to smoke. God knew we are going to have pollution. So he said, okay, let's give you an extra lung. You only need one lung to live. God gave us two lungs, or whoever gave us two lungs, so that we can have one extra spare tire or spare lung just in case. This is another way of looking at it. This is normal. The RV is very thin walled, no really pressure to be generated, because the blood easily flows from the right side into the lungs. And the LV is the muscular side, the side that creates the blood pressure. But as the lung vessels are starting to get thickened, as you can see over here, it is a schema, a drawing of it. The RV starts to thicken in order to maintain pressure in terms of the high upstream pressure, because in the high upstream pressure is high. But as the pressure becomes too high, the RV says, I give up, then it starts to fail. There's a lot of workup done for these patients, but as I said, echocardiogram is a nice screening tool. I get it done on patients who I feel have pulmonary hypertension. It tells us how the pressure is. It also gives us information about the valve. It gives us information about the right ventricle, the left ventricle, And then there's a lot of other confirmatory tests, and confirmation is right heart catheterization, which is going through the neck with a little catheter that flows with the flow of the blood into the lungs. And then it gives us the direct measurement of pressure, which are required in order to confirm the diagnosis. I thought I'll go through a case that may be more interesting. This is a 36-year-old male who has history of blood clots in the leg called DVT, and also had a clot in the lung. He had positive lupus anticoagulant, is one of the clotting factors were positive, and his DVT, first DVT was about 4 or 5 years prior. At that time, he was put on warfarin, but when he had blood, he was coughing up blood or hemoptysis. He was taken off the warfarin, and then in 2016 again he had again a hemoptysis, which is coughing up blood, and got admitted again. And then he was started on riociguat, which is a medication, a vasodilator for pulmonary hypertension. Echo, you can see over here, severely dilated right side, severely dilated right ventricle, severely elevated pulmonary pressures. I don't know how many of you can see this. It's a chest X-ray. It's not a normal chest X-ray. The heart is enlarged, and I've put this is the heart. This is very big. This is the pulmonary artery on this side, and the other one would be about here. This is the rib cage, and you can see this is the diaphragm. And so in this, the obvious thing is that their heart is big. The heart is usually half the size of the hemithorax, which is from here to here. So it should be half the size, and this is bigger. The lungs are clear. They don't see pneumonia or anything, but the pulmonary artery is enlarged in this case. So he had a CT done. CT is shown over here, and this is going from the very top to the bottom. And this is the right side. This is the left side. You can't see the lung. This is focused on the vessels, so therefore the lungs appear as black. And this is the pulmonary artery. This is so white because the contrast has been given over here, but you can see that the blood is flowing, but then the arrow, you can see that there's something in there, so it should be smooth, right? Because it's a tube, but you can see there's something dangling in there. That's the thrombus in this patient. And you can again see there's something over here, there's something over here. You feel that this vessel is going down, but there should be a vessel coming up too, right, over here. But you see that there's a cutoff here. There's no vessel going up. And same way on the other side also, you can see some black stuff there, some stuff over here. You can see this black stuff here. This is all thrombus that he has. Over here also you can see there's a line. There's a line there too. And this is the right atrium, right ventricle. This is all enlarged. And this is the liver, and the contrast you get is also going into the liver. There's white stuff there. Usually you don't see any contrast going into the liver, but it's backing up in the liver. And this is the lung picture showing you the lung. The lungs this is how normally the lungs are. This is the right lung, left lung. This is the trachea. This is the esophagus, and the vessels and the heart will come in the middle. This is the rib cage, and this is the sternum, and these are all muscles. So this is how the lungs are black, because they have air and they are lighter, and the tissue and the bones are dense because they are denser. That's how it is. But you can see that there is some haziness. As I'm pointing out, is that normally there's black like that, but you see this white stuff here. This white stuff here. This is patchy perfusion of the lung. The pulmonary artery in the middle is big, and this is then the heart is in the middle. The liver comes in there, so it's not very normal. And this is the perfusion scan, in which the dye is radioisotope is given into the vein. It is taken up predominantly by the lung, and it should be very smooth uptake. And this is the left lung, and this is the right lung. As you can see, the lung is there's a little bit of a black hole here, and you cannot see the top of the part of this lung there. So it looks like the lung is half, but it's actually not. It should be the whole lung. Same way over here, you can see that there is some perfusion defect, is what we call it, over here and here. And same way, you can see a wedge-shaped defect here. So there's a lot of defects. You can see this line of it should be smooth like this, but it's not. It looks like it's something is missing, something, sometimes we call it moth eaten, which means that there are areas which are, looks like they are missing. And this is what a normal looks like. As I just wanted to show you, you can see the normal lung has smooth edges, smooth uptake, smooth here, and but you go back and you can see that this is not smooth. So it's very patchy perfusion on this patient, and his PFTs were abnormal, lung function test were abnormal. That is what they have. 80%, 80 to 100 is normal, and you can see that his force expiratory vital FEV1, which is how much you can exhale in 1 second, was reduced to 68. Force vital capacity is 71, and diffusion capacity it was 62. And his walk distance in 6 minutes was also low. He's a 36-year-old guy. He should be able to walk at least 500 meters. He's down to 260, and his oxygenation goes down to 86%. So he qualified for oxygen. So what we will do next, we have to find out what the clots are, where are they, and then we can remove the clots or not. That would be the way to get rid of the clot and get the pressures down. Or if that is not the case, then we would manage him conservatively in terms of management with medication. This is a pulmonary angiogram, which is taking the patient to a cath lab and putting dye in the lung to see if it is evenly distributed throughout both lungs, which normally it is, and to see if it is not distributed, what are the areas that are being blocked by these clots. And you can see this whole right upper lobe is missing. Looks like he doesn't have this lobe. And you can see that these vessels are big over here, and suddenly they become small. You know, everything in the human body is very nicely organized, and it's very nicely, it tapers off. So big, small, small. So it's no sudden tapers. So when there is a sudden taper, then you know that there's a problem somewhere. You can see that this should be nicely open, but it's kind of narrow here, and then it gets dilated here, then narrow here. Same way on this side, you'll see a lot of perfusion this side, up in this, in the upper lobe, but in the lower lobe, this whole area, there's paucity of perfusion. Again, it becomes narrow suddenly over here. Looks like maybe a clot there. And so it's very abnormal perfusion scan. So we want to know how high the pressures are in the lungs to see what we can do for this guy. And so that we did the hemodynamics on him, and his pulmonary artery pressure was high. Normal is 20 and below. It was 43, so it was double. His right atrial pressure, which is the pressure that's blood going into the heart, is very high. So all these numbers are very bad. And his mixed venous was low. I don't know if there are any medical students there, but these are consistent with pulmonary hypertension, high pressure in the lungs. He has multiple blood clots. He had clots. He had coughing up blood. That's hemoptysis. He had submassive PE. He had, meaning clots, big clots in his lungs. He was started on anticoagulation. He was referred to us. We started him on some medication. His VQ scan was consistent with the chronic thromboembolic. He has severe pulmonary hypertension. So main thing is that the main definitive treatment for this guy would be to take out the clots, if we can take the clots out. So his case was presented in a multidisciplinary team, and agreement with the surgeon, with the anesthesiologist, with the radiologist, with the pulmonologist, with the cardiologist. We have a team that we meet every month, and the decision was that he needs to go through surgery. And this is when he went through surgery. These are the clots that came out of the lung. As you can see, these are very impressive clot. This is the right side, and this is the left side. So basically, after this was done, he became hemodynamically stable. His pressures actually normalized. I don't have that slide. And his chest X-ray improved. His perfusion scan improved. He had perfusion in both the lungs, and he basically was taken off his medicine. He was taken off his oxygen, and he did well. Of course, he would be on the blood thinner for the rest of his life to prevent recurrence of the blood clot. Although the clots are taken out, that doesn't mean the clots cannot come back. And the reason why he developed the clot, because he had a genetic predisposition. He had a lupus anticoagulant that predisposes him to form blood clots. Now we have medications approved through three pathways, and these three pathways, which is endothelin pathway, nitric oxide pathway, prostacyclin pathway, they have been targeted, and we have medications that we can actually give to the patient. This is the prostacyclin pathway. We have different medications which can be given by an IV, inhalation, sub-Q, and the oral tablet form we can have. So all these different formulation of medications. We have endothelin pathway, which is a very profound vasoconstrictor. So if you can give a endothelin blocker, that causes blood flow to go through the lung easier. And nitric oxide pathway, we have at least three drugs available. So on the whole, we have about 14 different drugs available to treat pulmonary hypertension. Then we also have and I just want to add that a lot of these medicines which are approved over here, we have participated in the clinical trials that have led to the approval of these medication at our center. So we are always participating in different studies. Right now, there are many drugs which are in development, such as the imatinib, which is a Gleevec, or it is a cancer drug, but has been shown to have the efficacy in patients with pulmonary hypertension. So it's an inhaled formulation is being tried, and there are two different formulations being tried. And then there's inhaled nitric oxide is also being tried, and then there's another powder inhalation, just like asthma medication. There are some certain powders that is being tried. Receptor agonist to the prostacyclin pathway is being tried. There are some new pathways such as sotatercept, which works through the growth factor pathway that is being this new molecule is called sotatercept. This is being investigated. We are participating in it. There's a new technique called denervation of the pulmonary artery that is being also evaluated for pulmonary hypertension. And there are many drugs. There's a long list of drugs which we have tested and they have failed. So how you test 10 drugs, and out of this maybe not even one, hundreds of drugs, and maybe one comes to the market. So the problem, so what do you do for these patients when they can't tolerate the drug, or they are at the very end stage of their disease? You can give them new set of lungs. Lung transplantation is the basic cure. That's the only one we have right now, unfortunately. So the Toronto lung transplant program came up because most of the time, I would say 10% of the lung is only usable. So when the lung comes, the surgeon looks at the lung and say, oops, no, it's no good. The patient smoked too much. The patient was in, God forbid, an accident or something like that. The lungs are not working properly. So they will say discard the lung. So they have come up with a plan where they would take the lung, they would actually perfuse them with different solutions, and then try to get these lungs improve, and they actually improve. So this is a lung that they took. They put catheter in the pulmonary artery, one catheter in the left side of the heart, and you can see that they are perfusing some bloodless fluid into the lungs, and then they're also ventilating the lung. This is actually a human lung that is getting ready to be transplanted, but they want to make sure that it's optimized, and then they put it in a little under a plastic thing to keep it moist, and then they work on the lung to improve it. They can even put antibiotics in this perfusate, and they can put some albumin in there. They can put different nutrients in this perfusate and get it healthier. Once the gas exchange in the lung is improved, it is ready to go into a human body for a transplant. That has been done actually, and it actually sounds like a Wi-Fi idea, but it has been going on for a few years now, and they have 5-year mortality after these patients have had these lungs in as compared to the regular lungs, and these lungs have functioned very well. So unsuitable lung making them suitable for transplant. So what about if we don't have lung for patient? Because the main problem is that patients don't qualify because they have to have the strict criteria, and the reason why the strict criteria is because we don't have enough lungs being available for transplantation. And then again, the lungs which are available, they are not they are not optimized, so they try to optimize them. But another thing would be, what about growing lungs out of human body and giving them back? So one is taking the lung and getting rid of the scaffolding. And once they get rid of the scaffolding, so the only getting rid of the cells, so the only the scaffolding remains, the only the lung structure remains, and then getting the patient's own cell to regrow the lung. That's one possibility, recellularization of the decellularized lung. That is happening in the labs. Stem cell engineering is happening also, regrowing lung from stem cells, and also 3D bioprinting, which I'm going to show that the human vasculature model is being created by 3D printing, and maybe that is the way to grow, we don't know. The other one is xenotransplantation. What about getting a pig and donating, taking their lungs, getting them optimized and donating it to humans? We know that pig skin has been used for burns, kidney failure. Kidneys have been used, pancreatic cells have been used. Now they are working on the technology in which they're taking the pig lungs. They are actually genetically modifying the pig genome, so that the humans, when they go into a human, it doesn't recognize humans as being foreign. So a new version of pig genome is being created. I think there are like 25 different genes that have been that have to be modified. I think there are up to like 10 of them have been already modified. So the plan is that if in patients who are 80-year-old, for example, or 75-year-old, they don't qualify for transplant, but they want to live, potentially that could be a possibility. So genetic engineering to make pig organs available for transplant. That's another. I'm just giving you the high level view of what other possibilities are out there. Now going back to Houston Methodist, the lung center, we take care of all these patients with different kind of diseases, and we are of course in Houston. Pulmonary hypertension, chronic thromboembolic disease. I review the case, ILD, different kind of ILD, asthma, COPD, and you name it. The other thing that I do in my spare time is also I help my alumni. So I'm from JSMU or SMC from Karachi. So I participated in the alumni organization in North America. And last year I was the president of that organization. So we had a lot of webinars, seminars, young physician guidance seminar. I've just put a few over here. We did a lot, even though it was COVID, we did a lot more. We had a very nice career option after graduation seminar where international faculty from Australia, UAE, UK, Ireland, Europe, Canada, America participated to go over different options that are available after graduation. So I went through this real fast, but I'm happy to take any questions. So the life, I don't know. It's just just hard work. I think everybody works hard, generally speaking. If you say even if electrician, ask him, he works hard. We all work hard, but the important thing is how do you manage your time? How do you improve yourself? Their life is not static. At least in medicine, you always have to learn new technique. You have to give exam every 10 years. You have to keep up with it, and it becomes part of living. It becomes part of life. And I think if I don't learn anything new, I would basically be very bored, because it will be very stagnant. So that's my take. Keep reading, keep learning, and dress up nicely if you want to be taken seriously. That's my thing for the youngsters, because I feel that people don't take that very casually. Even in America, Americans and all of us, if a student comes in well dressed, we consider that person is taking himself or herself very seriously. So we need to take that person very seriously, and what they're proposing may be actually serious proposal, meaning to do a research or participate or help out in a project and things like that. But if a person comes in dressed like they just woke up and they didn't dress up properly or didn't take care of themselves, and it will basically show that they are very careless in what they do. in their work also. So it's very important to do that prompt, be on time, actually come a few minutes before time for anything that you're doing. Submit whatever is due on time. If you cannot submit on time for whatever reason, send a note to your mentor or your professor saying that, hey, this is the reason I'm not able to submit, and whatever that genuine reason is, everybody understands. Always be on the lookout for new projects, new ways to help out, learn new things, and nothing is too small or too big. We all start small, and it all builds up. So no job is small. Going through the charts, or even volunteering and pushing the patient to one place to the other, that's how you get your leg in. So anything you can do is going to make a difference in your CV, and is going to get you doors open. um, I don't know if you have any questions for me, or if you want to ask. I'm happy to answer any questions.
Of course, thank you so much, Dr. Safdar. We really appreciate you taking the time to talk with us and your incredible life advice. I really appreciate it. And if anyone has any questions, they can feel free to ask now. We'll now begin our Q&A session. So to quickly introduce myself, my name is Manal Hill. I'm an undergraduate student at the University of Maryland studying physiology and neurobiology. I'm currently entering my 4th year at UMD, and I'm going to be asking you a couple of our questions from our audience. So our first question to start off was, what inspired you to pursue medicine in the United States?
So, I wanted to do postgraduate training. So I was looking at my option, whether you go to UK, you go to Ireland, you go to Canada, when I was doing many years ago, or you go to US. The path to US seemed very straightforward. You give your exam, and you get your residency and do your postgraduate training. In terms of UK, you can do that, but the problem is that they you cannot not everybody graduates. So there's a system where only the best graduate, and they have a system where not everybody gets in, and so it's more selective. It's not open, so therefore US was the choice. And my brother was actually here doing his postgrad training. He's also a physician, so that helped.
Thank you. Yeah, I definitely understand. And for our next question, how do you stay up to date on new research for novel treatments of pulmonary hypertension?
So, one, we participate in these studies. So, when the new studies are coming up, we are offered those studies. The other thing to do is that we attend different conferences. So, at least 2-3 conferences a year we attend, and we participate in different webinars. Now I have to say webinars, otherwise I would have said meetings. So we participate in different webinars. We participate in different meetings. We read what's coming out. We get updates on different treatment options and things like that. So you have to have multiple areas: reading, news, attending meetings, talking to people, talking to your collaborators.
Thank you. And for more on the clinical side, have you treated or worked with any patients diagnosed with COVID-19? And if so, how have you observed the disease affecting their pulmonary health in the long term?
Yeah, so I've had multiple patients with COVID-19, and COVID-19 basically affects the lungs. COVID-19 pneumonia, that's what it does. So pneumonia can be different kinds, I mean different grades of pneumonia. So it can be something like a little cough, you can't smell, can't taste, a little fever, stay at home, you'll get better, and the patients get better, so it gets over it. But the one that we see really are the ones that their lungs are severely damaged, and they end up in the ICU, they end up on the very high flow oxygen, they end up being on the ventilator. They Those are the patients, especially if they have lung problems to begin with, then the chances of developing worse pneumonia is even bad. So once that happens, a lot of time the fibrosis in the lung, it never goes away. The scarring in the lung stays. So it's very important that everybody should get vaccinated no matter what age.
Got it. Thank you. And for our next question, what is the prognosis of adults' pulmonary fibrosis?
So, prognosis of pulmonary fibrosis, which is a scarring of the lung, is bad. So, if you look at the old data, they say 3 years survival. So, but now we have at least two medications, FDA, at least three medications, FDA approved now to treat patients with pulmonary fibrosis. So, if there's a patient who has pulmonary fibrosis, they should be seen by a center, a pulmonary fibrosis center. They should be seen by a physician who knows how to treat patients with pulmonary fibrosis. Not every pulmonologist knows how to do that because it's a very specialized field. Most of us, when we are being trained in pulmonary, when we are doing fellowship, what we are seeing is the bread and butter of pulmonary, which is COPD and asthma, and pneumonias and cough. Those are things that we basically get trained in very, a lot. But we are not trained in the very different subspecialty, and if you are not in that field, then it's hard to keep up. There's a lot of literature coming out, a lot of new things coming out. So it's important to make sure to follow up with the right physician.
Got it. Thank you. So, actually, just going back to COVID-19 really quickly, which part of the lung is affected by the COVID infection?
Both lungs.
Okay.
Both lungs. Usually, actually, it's we have looked at multiple CT scans of these patients with COVID pneumonia, and COVID pneumonia can be anything. So it can be a little bit of a patch here, hair here. It can be all over the lung. It can be little pneumonia. It can be scarring. It could be some haziness. So you know what they say nowadays when a chest X-ray comes and CT comes and it has any abnormality, the radiologist writes in the very bottom, it can be possible COVID pneumonia for everything,
Um,
because we have seen that COVID pneumonia presents in very many different ways.
and do you know any mechanisms behind why it's presenting in so many different ways?
We don't know. I think what it is that the COVID virus it depends on how much inoculation the patient get, meaning how much is that the patient is actually inhaling. So the dose of the COVID virus that they were exposed to, the kind of COVID virus they were exposed to, or the immunity that they actually have, that they can mount, and also what kind of lung function they originally had before the COVID. So all those affects how they're going to present. Also, their own immunity, how good is their immunity or how bad is their immunity, will determine how their lungs are going to react. So, as you can see, there are multitude of factors.
Got it. Thank you. So, could the COVID-19 or pneumonia cause pulmonary fibrosis or eventually lead there?
It will potentially cause pulmonary fibrosis, and the question is that we are trying to prevent patients from with COVID pneumonia to develop fibrosis, COVID pneumonia to have full recovery of their lung function, so they are not oxygen dependent. Some of the patients are discharged from the hospital on oxygen, but then after 3 to 4 months they are able to wean themselves off the oxygen. So it's important if the doctor has given them oxygen, it's important to use it because it doesn't harm, it helps to heal. And then once they are able to take off the oxygen, we have done a few post COVID fibrosis which have been so advanced they ended up being transplanted because the lungs are so bad.
Mm, thank you. And another question that popped up from Sadia, are we using monoclonal antibodies for the treatment of pulmonary diseases, especially COVID-19?
Yes, absolutely. We are treating antibodies. So the body does not produce antibodies. So normally when we get an infection, we develop antibodies. That's how the body reacts, right? The body says, okay, oh God, this is not normal. This is not me. This is something virus coming from outside. I'm going to create a reaction and mount these antibodies, and these antibodies are going to go fight this infection. Those are my fighters, right? But in some patients, because of their immunity is compromised, they are on immunosuppressive medicines or different conditions, they cannot mount this antibody response. And we can check that response, we can check that by a blood level. And these patients then end up getting monoclonal antibodies to boost their immunity to fight the infection.
Thank you. And which type of pulmonary hypertension do you come across the most in the adult population?
Most of them have idiopathic, which means that you do complete workup and you can't find. And the second most common is associated with connective tissue disease, which is your lupus, scleroderma, rheumatoid arthritis. I usually look at the hands first. Somebody says, one of the my mentors used to say, your hand is the path to your soul. So you can actually look at the hands and they can tell you a lot of information about the health condition of a patient. So you can look at the nails. Nails can tell you what the shape of the nail will tell us if they're anemic, if they have clubbing, if they have lung disease, if they're blue or grayish or dusky, if they have any bending of the nails, if there's swelling of the nails, how they are, their palms, how is the skin, how the thickness of the skin, what is the shape of the hand. All these things can tell a lot about what's happening with the patient.
Thank you. And what are some other coexisting conditions a patient can have that may worsen pulmonary hypertension?
Coexisting condition that can worsen pulmonary hypertension if they have a lot of swelling, if they are not taking care of themselves, go have a Big Mac every day or every week. If they have, as I said, lupus, scleroderma, rheumatoid arthritis, if they were given oxygen and they don't use oxygen, if they don't take their medications properly. Having pulmonary hypertension does not mean that they're not going to have any other condition. They can still be diabetic, they can still be hypertensive, they can still have coronary artery disease. All those things have to be assessed and treated.
Thank you. And given your experience, how early can lung transfusion be done for end-stage pulmonary fibrosis?
Oh, right away within a few months. It depends on, it used to be the grading system that where are you on the list we used to depend on how long you have been on the list. So the minute they would get diagnosed, they would put on the list so that in 5 years' time they will be high on the list. But that was not fair to the people who already were at the time of diagnosis worse disease. So they would pretty much die because they are not on the list. They have not incurred enough time on the list to be on the top of the list. So it was an unfair system that was changed a few years ago. Now it depends on how they're doing clinically, like how much oxygen they're on, what's their functional capacity, how much they can walk, how bad is their pressure, how bad is their lung numbers, your FEV1, FVC. Based on those, they're given a number, and based on that number, the higher the number, the higher they are on the list. So they can be, you can say, okay, I'm going to refer a patient for lung transplant, and the patient is so sick on so much oxygen that from the very outset, they will be on top of the list just because
Thank
their
you.
lung function is bad.
Yeah, thank you so much. And what is the prognosis after lung transplantation?
So traditionally, it says 5 years, 50%, which basically means that you have a 50-50 chance. Now it says 60% chance, 60 to 40% chance of surviving at 5 years. So people say that's really bad, right? You have a 60% chance of survival, 40% chance of not surviving after 5 years. I tell these people, I tell the patients, you have a 100% chance of not surviving for 6 months. So if you get 60% chance, I would take it.
That's true. Thank you. And just speaking about bioprinting, are there any downsides towards bioprinting?
It's a new technology, so a lot of kinks and things to be worried about, and they have to be worked out. So it's in infancy right now for lungs. Lung is a very complicated organ. The problem with lung is whatever we breathe, it goes through the lung, right? Whatever we eat, whatever our whole blood volume goes through the lung. So lung is exposed to many things. And dear one, number two, there's a lot of different kinds of cells in the lungs. So, in order to regenerate the lung, in order to create that lung, is going to be at least a decade.
Thank you. And would the patient need to be on immunosuppressants after lung transplantation, and for how
Yes,
long?
yes, forever.
Forever. Okay.
Because there's somebody else's lung in your body, right?
Mhm.
So if somebody, so body is going to say, "This is not me. This is not my lung. Whose lung are these? I don't like them. I don't want somebody else's lung." So you have to tell the patient's body to not create that response, because if for example, I have had a couple of patients who stopped taking all their medications and their lung basically just got destroyed. Their own immunity destroyed the lung. And in order to prevent that from happening, they have to take immunosuppressive medicines. Initially, it's a hefty dose, but slowly it goes down as the body gets used to it, but they still have to take the immunosuppressive medicine for the rest of their lives
Got it.
religiously.
And what are the adverse side effects to these immunosuppressants since they're used over the long term?
The patient is going to be alive.
Mm.
The side effect, everything has side effects. On a more serious note, I was just joking. On a more serious note, everything has side effects. You take Tylenol, if you look it up, Tylenol has a multitude of side effects. If you take aspirin, it has a lot of side effects. If you take Aleve, ibuprofen, any of the medication that you take, everything has side effects. Similarly, immunosuppressive medicines have side effects. If you have too much immunosuppression, then your own immunity has gone down so much, has been suppressed so much that you are predisposing yourself to infections, different kind of infection that you normally would be able to fight off. So the immunosuppression has to be carefully managed, and the blood levels have to be checked periodically. So they have to go to the clinic, they have to get their blood work done. So it's an involved thing. It's not like everybody is a candidate for lung transplant. Not everybody can tolerate lung transplant. Not everybody is going to be compliant with the lung transplant. So it's not everybody's cup of tea. So it has to be, the patients have to be carefully selective. As the person who's asking asked a very good question. It has you have, it's a big commitment. So, if the person is ready, the family has to be ready for the commitment too, because somebody has to bring the patient in, and the patient is not feeling well. They need to bring the person into the hospital. So it is, but the that's the downside. The upside is this, that they will be alive.
Thank you. That's very true for sure. I know that there's a trade-off, but I know a couple of students have been brainstorming between these alternatives to immunosuppressants. So after transplant, they were thinking, could there be any immunosuppressants that don't have as many side effects, or possibly through stem cells, could they not need to use immunosuppressants?
So those are all good options which are being explored. So what immunosuppression the person needs, it's all individualized medicine. So the degree of immunosuppression, the amount of immunosuppression, the dose of immunosuppression, the kind of immunosuppression, all has to be tailored to that patient, that person. And of course, can you make the lung, before you put it in the patient, can you make the lung similar to the recipient's lung, so that the recipient lung does not consider that as foreign by genetically modifying the lung? Right? That's the question.
Yeah.
That is being worked on. A lot of research going on in that, the genetic modification.
I'm excited for that research. What is the first sign of pulmonary fibrosis?
Usually, the first sign is cough, a dry cough, shortness of breath. They can be sitting there, no problem, but they start to walk or do anything exertional, going to the grocery store, doing their groceries, picking up bags, bringing them in the car. So, oh, I'm short of breath. So most of the time, the patient ends up in the go to their primary care. Primary care says, oops, it must be heart. So they went to the cardiologist. Cardiologist says, I need to do a stress test. The first thing they do is EKG, stress test. Oh, it's normal. It's not your heart. Go to your pulmonologist. So then the patient goes to a pulmonologist. Pulmonologist says, oh, must be asthma. Take this inhaler. So the inhaler doesn't help. Oh, you have a cough. Let's get a chest x-ray. Okay, they get a chest x-ray. Chest x-ray shows that they have fibrosis.
Okay, sounds like it's a commonality of going through the cardiologist and the pulmonologist. And
Yeah, usually that's how I see the patients coming along. Because most common cause of shortness of breath is heart.
Mhm.
And common things being common.
Right. Thank you. And are there any preventative measures for pulmonary fibrosis, or is it genetic?
So, so we are talking about pulmonary fibrosis. Yes, pulmonary fibrosis can be genetic. So there are papers coming out, and they have already been published a couple of years ago, saying that there are about more than 100 families that have genetic mutations that led to pulmonary fibrosis. I have one patient in the hospital today, actually admitted he has bad pulmonary fibrosis due to a genetic mutation. His father had it who died, his brother had it, he got transplanted. He's on the transplant, he's going to be on the transplant list soon. He's almost completed the transplant workup, and he has pretty bad fibrosis. Young guy, he's about 40, but he has genetic mutation that led to early pulmonary fibrosis.
Got it. Thank you. And I'm not sure if you heard of the Pulmonary Fibrosis Foundation, but I know that that is a foundation that is used for pulmonary fibrosis. So, like, do you know how the Pulmonary Fibrosis Foundation helps?
So I'm the director of the Pulmonary Fibrosis Foundation Care Center in Houston Lung Center. There's the other thing that we do is that we work very closely with Pulmonary Foundation. I'm on their steering board, the steering committee. We worked on different projects. Like right now, we recently published a paper looking at the role of lung biopsy in patients with pulmonary fibrosis. We do different projects looking at different data. We gather data. All the patients, all the sorry centers who are who are associated with Pulmonary Fibrosis Foundation. We submit data. We are part of a registry, and then we have a pool of data. As you can imagine, there are more than 30 centers throughout the U.S. We pool the data, and then we look at different questions, and then we try to answer them and then publish that. That's one way of helping by PFF. The other thing is that there is a patient groups that hold meetings with through PFF, through different support groups meeting. We have a PFF support group in pulmonary fibrosis support group in Houston. I'm on one of the board of one of the those support groups. We go and we try to help them with oxygen. We have educational seminars with them. I get invited to give different talks to them. I did not go over what other things that I do. The other things that I do is I give talks like this to patients, to students, to medical students, to physicians out in the community. So different areas in locally, nationally, and internationally. I also educate physicians and colleagues in Karachi, Pakistan, my alma mater. I also educate other ICU physicians and things like that. So we do a lot of teaching throughout the US and throughout the world, and we try to help out as much as possible.
Thank you. I really appreciate you serving humanity to the fullest capacity. I'm going to pass over the Q&A session to Hamza. He'll be asking the remainder of our questions.
Thank you so much for the session, and thank you for passing over the questions to me. My name is Hamza, and I'm from New Jersey. I'm matriculating into a joint BSDO program with Seton Hill University and the Lake Erie College of Osteopathic Medicine, both in Pennsylvania. The first question I'm going to ask is, what is the difference between pulmonary fibrosis and ARDS?
So ARDS is the end result of it. So if you have, let's see, what example can I give you? If your car is broken, right? Your engine is not working. You have a, I don't know, muffler drop off or something like that, right? Something is technically not working, and that lead to the car not able to function. So basically, what the lung fibrosis is scarring in the lung, and when there's enough scarring of the lungs so that the person cannot breathe, they had to be their oxygenation goes down to a certain degree, then it's called ARDS. There is a specific definition of ARDS, which is separate from acute lung injury. And if they need high amount of oxygen, their oxygen transfer capacity, because what do our lungs do? Our main function of our lungs is that we can breathe in oxygen and exhale CO2. If that basic function is compromised, that we can inhale oxygen, but not enough oxygen goes into a bloodstream, we need extra oxygen that patients have. But when the amount of that extra oxygen that's required is very high, the PaO2 FiO2 ratio is high, then that's the ARDS.
Thank you for that answer.
One other thing is that the cause of ARDS can be many. So end result is the poor functioning of the lung. What led to the poor functioning of the lung can be COVID pneumonia, can be different other kinds of pneumonia, can be your aspiration, that the people aspirated, they had a seizure and they aspirated their food contents into their lungs. It could be pulmonary embolism. It can be many causes.
All right. Thank you for the answer. Here's the second question, which is somewhat related. Does COVID-19 develop pulmonary fibrosis or ARDS? ARDS, you said, could be caused by COVID, right?
Yes, 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 exactly. So, yes, COVID pneumonia, nowadays we are seeing more and more patients with COVID pneumonia. They are actually being discharged on oxygen. So, which means that their lungs are healing, but to not to the point where they were before they went into the hospital. So patients may get say, okay, I was not on oxygen. Why are you giving me oxygen now? Why do I need oxygen? It's because your lungs are now not able to transfer oxygen as efficiently. Therefore, you need extra oxygen, and your lungs have developed fibrosis. Now, will they recover? Most of these lungs will recover, but there will be some patients whose lung will not recover, and they will have the chronic fibrosis for a long time.
Thank you for that answer. You just answered this: is COVID-19 lung damage reversible? So what are the cases where it wouldn't be reversible?
So if the patient already has lung damage to begin with, for example, they are smoker, vaping, hookah, whatever you call it, and their lungs are already inflamed, they're compromised. On top of that, they have now another injury, which is your COVID pneumonia, which is a severe pneumonia. It's not a mild pneumonia. If it was mild, then people would have a little cough, little pneumonia, little bronchitis, and they will be fine. But we see more and more patients ending up in the hospital, especially in New York and New Jersey. At the peak of the pandemic last year, June, July, they didn't have any masks available, they didn't have any PPEs available. We actually, through our alumni, arranged delivery of a mask, the N95 mask to a lot of New York hospitals through their program directors to help the doctors fight and be protected themselves. So it's a reality that we have to face, that this COVID virus is a severe virus. It leads to a lot of lung damage. We are still learning about it, but there's a lot more to learn.
Thank you for the answer. Is there any role that any role of ECMO in COVID-19 pneumonia?
Absolutely, absolutely. Whoever asked these questions is I'm sure is a med student or a resident. ECMO, what ECMO means is that it's a extracorporeal membrane oxygenation. The patient's lung is not working at all, and they are not able to oxygenate at all. Basically, patients are connected to a ventilator, given 100% oxygen, or given high flow 100% oxygen. Even with that, their oxygen saturation in the blood is low to the point that they will die. Now, what can you do? Well, nowadays, with the last viral infection, they had developed these small little portable ECMO oxygenators. They are the extra outside the body oxygenators that the patient can be connected through cannulas, and this oxygenator works as a outside lung, oxygenate the lung, and that blood then is given back to the patient. And this can happen for months to weeks, and till the lung recovers or till the patient get a lung transplant. So it's a bridge. It's not a definitive. You can't go home with it. Like LVAD, you have to have it as a bridge in the hospital. We had one patient who was on ECMO for I think 4 or 5 months before he got transplanted, and he was a young guy. Nowadays, that technology has really improved so much that patients can even have an awake ECMO, that they can have these cannulas and they can be walking around with an outside oxygenator connected to the catheters in their body.
All right, thank you for that answer. The next question we have is, have you seen patients who received the COVID vaccine and still get COVID pneumonia?
Yes, because it depends on what kind of mutation they have. The COVID virus is very smart, right? You want to sneak out of the house. Your mom or your dad find the way that you are going through this door. They're going to lock their door, but you find another way to sneak out of the house, right? So this is the COVID does is it finds a way that to fool the immunity, fool the body. So the people found a vaccine to block that mutation, to block that virus from acting. Now the virus mutated, found another way of affecting the body. So the vaccine is effective against this way, but now the virus has discovered a new way, has mutated a different way. So now the vaccine is not protecting against that new way. So how it affects the body. So that's why you can get a COVID pneumonia even though you have the vaccine, because that the mutation that you got, the vaccine is not protected. So the new mutation that's coming from India is very bad. A lot of patients are getting sick. A lot of patients are getting pneumonia again, even after vaccination. Number one. Number two, the vaccine effect wears off. If you remember, you get flu vaccine every year. You don't get one vaccine and you're done for 5 years. You get flu vaccine every year. There's a time frame when the vaccine works and then it fades off. For example, tetanus, you have to get it every 10 years. And in the same way, the COVID vaccine, when you get COVID, patients get COVID. The COVID, having COVID creates antibodies, as we discussed earlier, and that antibody stays in the body. We think around 3 months, 3 to 4 months. After that, the immunity that you got from getting the COVID virus or COVID infection wears off. So 6 months later, they didn't get the vaccine. They thought they were protected. 6 months later, after getting a COVID virus, now they end up with a pneumonia, and they're asking, why do I get the pneumonia? Is because you never got the vaccine, and the immunity that you developed from having COVID weared off after 3 months.
Great. Thank you for answering that question. Another question we just got about COVID was, can people with autoimmune conditions receive the COVID vaccine?
You have to talk to the rheumatologist. Yes. The short answer is yes. You have to talk to the rheumatologist, talk to your doctor. They will advise you as to how to manage your medications, your immunosuppressive medicines, and get the COVID vaccine. I will give you one example. Patients who are post transplant, liver transplant, kidney transplant, heart transplant, lung transplant, all those patients that are followed at our center, those patients got the COVID vaccine. So they were severely, heavily immunosuppressed, but they got their COVID vaccine. That tells you that the answer is yes, but we just have to time it right.
All right. Thank you for that. This question we have is, can you go over the mechanisms behind the mean pulmonary pressure graph as to why when cardiac output increases in pulmonary hypertension patients, pulmonary pressure starts to rise?
So in patients with pulmonary, so it's like if you have a pressure, if you have a pressure in the pipe, your garden hose, you have a pressure in the garden hose, right? And then you stand on it, you stand on the garden hose. What will happen? The pressure in the garden hose is going to rise before it gets to your foot when you're standing on the garden hose. Same way, if you have pressure in the lungs that are increasing, the pressure in the lungs starts to rise. So how does the cardiac output is generated? The cardiac output is generated by the left ventricle and the right ventricle. So these are the pumps. If the pressure is high, the heart has to pump harder and harder and harder. A point comes when the pressure is so high that the heart cannot keep up and starts to fail. That's when the cardiac output starts to go down. So initially, the pulmonary pressure goes up, the cardiac output goes up because the heart is able to keep up. But a point comes when the pulmonary pressure keeps going up and up and up and up and up, and the heart cannot keep up, and the heart starts to fail because heart has a capacity and it cannot keep up with the pump. The pump is failing. Basically, it's just a mechanical failure. I hope that answers the question.
Yes, that does. Thank you for that. Our next question is, how long can a patient typically survive after gene therapy?
So the gene therapy now is basically it's still experimental. It's being tried in animals first, and hopefully it will come to humans. There are some genetic therapies which are available for different diseases that is approved, but there are very few of them.
Right.
So, for example, I will give you an example. For cystic fibrosis, cystic fibrosis is a type of bronchiectasis. The patients are born with a gene mutation, and delta 508 is the most common gene mutation. And there are other gene mutations. There are medications now available that improve the expression of the receptors. So those medications are available, and patients with that specific mutation can get those medications. But then again, it's not available for everybody, and there are certain specific diseases where we have medications that target expression of receptors, or whatever is altered in their body.
Thank you for that answer. The next question we have is, what primarily inspired you to pursue pulmonology over other specialties?
So, I was mentioning earlier that when I started doing my rotations in medical school, you go through all these different rotations, right? You go through internal medicine, you go to nephrology, you go to cardiology, dermatology, ENT. You go through all these, and you have like 2 weeks rotation through all of them in your clinical rotation. So I really liked ICU medicine and the ER medicine. Those are two things that I really liked. And in the ICU, if you're doing ICU medicine, you have to combine it with something like pulmonology or cardiology or ER or anesthesiology or surgery. And I did not like any of the other ones. So I looked at ER and I looked at pulmonary critical care. And the reason I didn't do ER, it really your your personality and the way you are will come through, and your body and your brain will tell you what you like. I really did not like ER because I hated the 12-hour shifts. I just could not function after 10 hours. So I wanted to go home, so I could not do 12-hour shifts. So I could not see myself doing ER for the rest of my life. So I really like pulmonary critical care. I think that really gives the whole, you really take care of the whole body of a patient when you're taking care as a pulmonary critical care physician.
All right, thank you for that answer. And our final question will be, do you know of any online research opportunities available to students?
Yeah, it's a tough thing right now with COVID. But what we are doing is that if you are a student, you can check with your school, your undergrad college, if they have any affiliation with any hospitals or any universities, so that you can be part of some remote projects, such as going through charts, reviewing data, doing some computational work, for example, maybe part of surveys. So one way is to find out if you are affiliated with a college or a university. That's one way of doing it. The other way of doing it would be to maybe join some different companies and see if you can get experience with it. Another way, actually, which maybe some people don't know, is to work as a medical assistant, MA. Medical assistant are people who bring you, when I'm going to see a doctor, they bring me into the room, they do my blood pressure, they review my history, they review my medication list and update it in the computer. I know a couple of medical students who are actually working as MAs. So that is one way that you get exposure. It looks good on your CV, and you can actually have some kind of a relationship with the physician that you're working with, and they can even give you a project. So there are different ways of find. There is no one website that you can look at to find out if there are. You just have to look around and talk to your physician in your community and see if people have different ideas. And if you have specific questions, you can email me. There is one question I'm reading. It says that what type of test do you have to take every 10 years as a physician? And I just wanted to address that. It's every physician have to be board certified. So that board certification exam usually is every 10 years. So for me, I'm board certified in pulmonary critical care, first internal medicine, then pulmonary and critical care. So keep my certification, I have to take a board exam every 10 years. which is not fun, but you have to do it. You have to go through all the data, you have to review everything, and then sit through a whole day of exam to make sure.
Thank you for that extra question as well. Those are all the questions that we have.
Okay, I'm happy. Thank you very much for inviting me. This was very, very interesting, very nice. I loved it. Thank you so much.
Thank you so much, Dr. Safdar. We truly appreciate you taking the time to answer our questions. I'd love everyone to please give a warm thank you to Dr. Safdar in the chat box for this incredibly informative session. Now we're going to conduct our closing session with our quiz and future session dates. The link to the quiz for this session is now live. Again, you'll need a 70% or higher to pass and receive certification, and the link to the quiz will be sent into the chat shortly. Additionally, many of our students have expressed interest in pursuing a leadership position in teleshadowing. We do have positions open on our leadership page, as we strongly believe in extending opportunities to others, and that's at www.teleshadowing.com/leadership. Now on to our next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. I'm looking forward to seeing you all at our next session, which is next Saturday on June 5th at 10 a.m. Eastern Standard Time with our physician mentor specializing in neurosurgery. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.